Claro, no lo encontrás porque estás en otro lugar, estás como espectador.
Welcome everybody, it's 3 p.m. Italian time, and indeed it is time to say benvenuti, which in Italian means welcome, and we start by welcoming you with the image of the Italian pavilion at the Universal Expo of Dubai that is created with this amazing roof made by 3 upside-down boats, as a metaphor, I would say, of the journey we are all having in this time, of course, quite challenging considering the pandemic, but also providing the opportunity online to gather together to connect experts informing patients. I deeply thank all the ones who have already joined this educational global teamwork, starting from our colleagues and friends from China, Latin America and Africa, and all the other regions. And a special thanks to Professor Taha and Professor Bishara and Professor Simkin, and of course, Oscar for the LATAF project. A special thanks also to all the colleagues and friends who started with us last week, the very first step toward the ACHIEVE project, that is indeed the acronym of Advances in Comprehensive Venous Education, looking forward for a 360-degree knowledge in venous disease. We look forward, of course, for being together in Dubai during the Universal Expo. That will be a unique opportunity to connect minds, creating the future, and in particular with the winter meeting to connect experts to properly inform patients. This will be truly a spectacular venue, the one of Dubai during the Expo, because all the nations, more than 190 countries, will actually show their best. You see over here the different pavilions, and we look forward for seeing your nation pavilion. And the 4 you see reported over here are in honor of the 4 languages in which we will enjoy simultaneous translation in today's webinar. So remember to select the language you prefer in the interpretation button. Remember, you can make questions in whatever language, not just these 4, but whatever language you prefer in the question and answer box, and get your chance to have the answers from the huge speaker of today, Professor Caprini. We deeply thank the huge speakers of last Saturday for answering to all the questions that were reported in the question and answer box. This Saturday, we focus on the clinical aspects of the project, so venous thrombosis and chronic venous disease in the clinic. And nothing would have been possible without a truly stellar faculty representing all the continents, and nothing would have been possible without huge colleagues and friends you see reported over here who co-worked with me in delivering also extra educational material you can find in the dedicated educational platform. Today, we will provide international CME credits, so just write to the mail to claim your credits and certificate. Nothing would have been possible without the unbiased support of Alpha Sigma as a main supporter and Media as a supporter. We deeply thank both of these supporters. But of course, I like to personally deeply thank the colleagues I consider also family and great travel mates. So Professor Bottini, the mic is for you now.
Thank you, Sergio. Dear friends, once again, it's a wonderful opportunity to be together with friends and experts from all around the world. Remember, you can make questions in Spanish, either live or in the Q&A box. Thank you.
Thank you, Oscar. Now we fly all the way to US with Willie.
Good morning, good afternoon, good evening, everyone. Let's enjoy our show again. Please go ahead and make whatever questions in your native language, and we'll be happy to answer them.
Thank you so much, Willie. And now, as always, we have the tradition of starting with the blessing of a huge professional figure. And this week, we are so honored in having with us Professor Roberto Simkin from Argentina. Roberto, the mic is for you. Unmute yourself. Roberto? If there are some technical troubles, we can proceed. We have his video here.
Dear friends, thank you very much for such an honorable invitation to participate in such an important symposium. Thank you, Dr. Gianesini, Winchia, Dr. Bottini, for allowing me to participate and share this event with colleagues and so important from the world of phlebology. Congratulations.
Thank you so much for the blessing. And now we get started with the scientific part. And since this is a scientific journey, we always try to keep a light atmosphere in these quite challenging times, coupling with a metaphor our huge figures with great explorers, adventurers. And in this case, we couldn't go bigger. And indeed, I thought about Apollonius of Perga. Maybe you don't know that Apollonius of Perga was one of the inventors of the astrolabe, because indeed, Professor Caprini is the one who is guiding us all around the world in the proper navigation inside the thrombotic risk assessment. So it's my huge pleasure to introduce the giant we all have the honor of walking on the shoulder of. So Joe, the mic is for you. If you want to share your screen, unmute yourself. And we can see you perfectly. And we can see your slide, go full presentation.
Well, good morning and good afternoon and good evening, wherever you are. And this is indeed an incredible honor to be asked to participate in this worldwide collection. I'd just like to say that despite the horrors and the terrible things about COVID, one of the things that I think COVID has done for all of us, and I think it's almost biblical, it's forced us to turn to one another. And nothing is more important and more emblematic of that than today's symposium and everything Sergio Gianesini has done to bring the world together. And I'm just so excited to be with colleagues from all over the world and all disciplines. And we're all getting together. And I feel closer to all of you than when I was trying to travel, because we can do so much of it so quickly now with the electronic platform. That having been said, today I would like to provide a little bit of a personal update about the COVID-19 pandemic. And I would like to start by talking about history. We have learned that not everybody will fit in the same shoe. We understand that individual risk assessment is mandatory. We also understand that the degree of prophylaxis or prevention against thrombosis relates to the amount of risk that there is to begin with, the baggage of the patient, the risk factors of the patient. We understand now that this risk assessment not only has to be done at the beginning and thoroughly, but it has to be continued through the hospitalization and continued post-hospitalization. We know most clots occur after patients go home from the hospital. Now, I have a question. When I'm seeing a lot of the authorities talking about this, they're saying, we don't know what to do. We don't have data. Well, I would like to emphasize the fact that we have 30, 40 years of data to draw upon. And until the new data shows that our old postulates are not proper, then I think we need to incorporate what we have learned with history. These are my disclosures. And I would like to start with the Caprini score. The reason that I favor this score really is not because my name is on it, because a lot of other people's names should be on this, because without a lot of other people, this score would never have gotten to where it is now. But it's the most thorough and comprehensive history and physical, yet validated in our environment. There's 5 million patients in clinical trials involving 200 studies that have shown the value of a thorough history and physical. And one of the unique things is we know that as the number of risk factors goes up, the incidence of thrombosis goes up. We also know that each risk factor has a different power. Bed rest is a low risk, cancer of the pancreas is a high risk. So taking the powers of those risk factors as well as the number of risk factors and putting them together in this equation, which has now been validated around the world, we come up with a score. And as the score goes up, the incidence of venous thrombosis goes up. It's a non-logarithmic progression. And here we see it in general surgery, for example. And the over 8 risk is a very high risk category. But the risk score, the set point varies with populations. In otolaryngology, for example, until you get to 8, nothing much happens. Very low incidence, very, very low. But then once you get over 8, it goes up almost to 20%. So you have to take a look at this for your own individual specialty. Now, we know that capturing all these elements is a time-consuming process. What have we learned? Patients love to get involved in their healthcare. Involve them in their healthcare. Have patients do that. And I would like to have Sergio help me with a worldwide initiative to get every patient, every person to do their risk assessment today, and then take it to their doctor, get it validated by their doctor, and put it in your medical record. When you come in for surgery, or when you have a COVID emergency, or a traffic accident or stroke, nobody's going to ask you 40 questions. That just isn't going to happen. And if it's not in your record, your real baggage might go undetected, most notably a family history of thrombosis. This patient-friendly risk is in many languages, and it's very easy to do. I'd like to point out 2 things. As far as I can tell, this is the only risk assessment out there that talks about obstetrical complications in the history that could be a signal that the patient's carrying the antiphosphate antibodies syndrome. And this is a very powerful syndrome. It consists of antiphospholipid antibody, lupus anticoagulant, and beta-2 glycoprotein. These people can carry these defects their whole life. And if you miss that, that's a great reason why these patients otherwise who would do well would die. Another thing that I'd like to point out is that the family history of thrombosis. Now, to my knowledge, some of the risk assessments talk about thrombophilia, but you know that's a very small percentage of patients who have a family history of thrombosis. To my knowledge, the British Health document, the National British Health System document, is another one like ours that talks about a family history of thrombosis. And I think that's very important. Also, I'd like to point out that, you know, we're talking about Caprini score. It's not the only road to Rome. Matter of fact, the National Health Protocol in England that in the United Kingdom that has been nationalized has led to a lower death rate. Very powerful data. So by all means, although I prefer the Caprini score and we use it, whatever score you use and you're comfortable with, you need to do. The point is, don't forget to score the patient. Now, the other thing is that during hospitalization, patients have various problems, including reoperation, infection, central lines, cancer, and the score needs to be updated, and then often will dictate a change in the post-discharge prophylaxis. If you have a patient and all of a sudden the patient comes in very low risk and then has a serious infection, they leak from an anastomosis, if they have cancer diagnosed, they need a central line, that may vastly change your approach to that patient. So it's a dynamic instrument. Now we have proposed, and this has been under test now in Moscow and in our center, that patients with COVID, we assign them an additional 2 points if they have the virus, 3 if it's symptomatic, and 5 if the D-dimer is positive. Why in the world would we do that? Well, what do we know about COVID? COVID is laced with thrombosis. And so if anything, these patients are at higher risk than the normal patient for thrombosis. So we are sticking our necks out here and taking a stab at increasing the risk based on the fact that COVID is laced with thrombosis. And time will tell whether this is correct or not. Now, what do we know so far? Well, COVID is a virus-induced inflammation, and it triggers a cytokine storm causing tissue release, thrombin generation, fibrin formation to coat the virus and prevent spread. What a really nice mechanism. Unfortunately, the side effect is thrombosis, DVT, PE, stroke, arterial thrombosis. Microthrombosis may occur in the lungs, liver, and so forth. Fibrinolysis may occur to dissolve the thrombin, and a DIC picture can result. Now, what is unique about this is, let's go back in history. We know that the activation of the Hegeman factor, factor 12, thanks to Oscar Ratanoff, has taught us that the activation of that factor can activate platelets, leading to thrombosis and platelet plugs, coagulation, fibrinogen to fibrin, leading to thrombosis, fibrinolysis, plasminogen to plasmin, with lysis of the clots, inflammation with elaboration of cytokines, IL-1, IL-6, and in addition to that, the complement activation, and then the kinin activation, when bradykinins increase vascular permeability, vasodilatation, shock, hypoxia. All of these things we know can occur with contact activation. Now, what do we have with COVID? We have the tangled web, as I like to call it, on steroids. And in addition to that, the virus is like a spear, and it can pierce like a spear the endothelial cells all over the body. So we've got all of these reactions going on all at one time. Now, there is no question that anticoagulation alone is not the answer. And we all need to get together now, the clotters, the inflammatory doctors, and the immunologists, and work together, not just keep jacking up the anticoagulation alone, not just using antivirals, not just using anti-inflammatory drugs like steroids. It's got to be a combined effort. You realize how complicated this is? And the virus has a predilection for the alveolar endothelial interface, which is that very delicate place where oxygen is exchanged. And because of these reactions that all go on in this location, of course, pulmonary insufficiency is rampant. And what do we know now that's new, that's really new? Primary pulmonary thrombosis occurs. And in addition to that, there's also pulmonary hemorrhages, which is another reason we have to be a little cautious about just going full blast with anticoagulation. All of that having said, we came up with a you might say brazen or off the wall or speculative guideline. We started out with a speculative guideline that we felt that, and this was way back in March and April when this thing first happened, that all patients should receive heparin or low molecular weight heparin prophylaxis due to the high risk of thrombosis. We also believe that risk assessment is necessary on admission, and we also noted that the punishment fits the crime, Gilbert and Sullivan. If the patient has a lot of risk factors, you've got to give them more prophylaxis than normal, because we know that breakthroughs occur. And then if scoring on admission is not feasible, make sure that you score the patient at discharge and due to the high incidence of post-discharge thrombosis. And I'd just like to stop for a minute because I've got to give away a punchline. We now have seen, there was just a recent article out of New Orleans that was 6,000 patients, and they were all followed the standard guidelines of giving everybody prophylaxis in the standard dose, no increase in prophylaxis and no therapeutic prophylaxis by and large. And they reported a 50% breakthrough on those people that got standard prophylaxis and then they got a thrombosis, which in a sense is semi-validating what we're trying to say. But what we're trying to say is based on history. We just didn't pull it out of the air. We know this from the past. What also do we know? We know that back in the 2008, everybody forgets, not everybody, all of you people around the world are very tuned into the RIETE database. Fabulous database. God bless Manuel Monreal, Juan Arcelis, and all of those people and all of the 200 or so hospitals from around the world that have contributed to this real world database. We know that 77% of people, when they get home from the hospital, develop their clot, and half of them after anticoagulation was stopped. And that was in 2008. Guess what? In the latest issue of the Journal of Vascular Surgery, Venous and Lymphatic Disease, or coming up very soon, is the additional publication updating the RIETE database. And guess what, folks? Shows exactly the same thing. We've got to provide this outpatient prophylaxis. What's changed? Not only is it important, but now with COVID-19, it puts a whole new emphasis on protecting people when they go home. We know that patients, when they go home, have a very high incidence of complications. I've seen a couple of brief reports where they said, well, at 30 days or at 23 days, there's a very low incidence of thrombosis. That's you have to do a proper 90-day trial, taking all comers and taking it by their risk level in order to really find out the answer to that question. And I assume when the day is done, that just like between 2008 and 2020, the incidence didn't change, the percentages didn't change. It's going to even be worse with COVID, I would predict. Now, the other thing is, we know there's already a lot of data out there going back to the trials using low molecular weight heparin, fondaparin, both enoxaparin and dalteparin, that out of hospital patient prophylaxis works. And now with the new DOACs, there's new data that indicate the value of that. So while we don't like to use the DOACs during hospitalization because of all the different medications and other problems, giving patients DOACs for a period of time following discharge, we've got data on this, and we need to be applying it to these COVID patients. So I'm sorry to rush through this, but I just wanted to say that in summary, it's very important to perform thrombosis risk assessment using your favorite tool. The Caprini score, the Padua score, the improved score, the British score, whatever your score, you've got to score these patients. You can't put everybody in the same category. Understand the widespread involvement of the vasculature in this disease. The SARS virus piercing the endothelial cells like spears. Pulmonary thrombosis and alveolar-induced damage are prominent features of the disease, along with pulmonary hemorrhages. Remember, arterial venous thrombosis can occur anywhere, and tailoring the intensity of the anticoagulation is the key to success. That is not rocket science. We know that's been proven, and the breakthroughs are related to inadequate anticoagulant prophylaxis. Ultrasound screening, you have to be very specific about that, and for given indications only. And post-discharge prophylaxis is required for most patients. Now, I'm just holding in my hands the latest article I have out of Sweden, showing that the dosing of thrombosis prophylaxis related to mortality, that it does help patients who have a full dose anticoagulation or intermediate anticoagulation or low dose anticoagulation. It did help with mortality. So more to come. Thank you very much for your attention, and it's a great honor to be a part of this international community, and I look forward for many more interactions for all of us to come. Thank you very much for your attention.
It's all of us deeply thanking you, Professor Caprini, as always, for being our best example to follow inside and outside our professional field. Now the honor for these 4 colleagues and friends from all around the world to be your expert discussants representing their continents. And we started from Latin America with the president of the Paraguayan Society of Phlebology, Professor Roberto Corbetta, who is with us. Roberto, the mic is for you.
Buenos días a todos, muchas gracias por la invitación. Y yo quisiera hacer una pregunta al profesor Caprini. En artículos que se han publicado que hablan del tromboembolismo en el perioperatorio y la aplicación del score de Caprini, habla en diferentes especialidades, pero no he leído ningún artículo en el que se hable de la cirugía ortopédica. Entonces, ¿cuáles son las áreas médicas en las cuales usted aconsejaría el uso de los anticoagulantes?
Thank you very much. That's a very important question. It seems like it takes a long time for literature to get out into the general public. And not only that, but to overcome the biases. Orthopedic surgeons, quite rightly, when they looked at the original chest consensus conference that now is recommending the Caprini score, everybody over 5 is high risk. And then they looked at the Caprini score and they say, well, every joint replacement is a 5. So that doesn't apply to us. That doesn't make any sense. But that was in 2012, folks. We now have a number of papers in orthopedics. And what have we learned? We've learned in orthopedics that patients who as far as joint replacement goes, if their score is 10 or above, that the incidence of thrombosis is high in that group, and they should have a traditional anticoagulant. If it's 9 or below, aspirin works just fine, and these patients have a very low risk of thrombosis. There's now 2 papers have been out there and big studies from New York over the last year, and it seems like nobody's looking at those. They're looking at the Batman. There's a Batman study in orthopedics, and I'm sure, I hate to say this, but it looks like the authors were trying to prove how the Caprini score didn't work. So they took a look at the Caprini score and total joint replacement. They looked at 12 factors. We have 40 factors. That's not looking at the Caprini score. That's looking at a little segment of it. Not only that, but they didn't draw the right conclusions, and there was a gross disagreement between people doing the scores. And another thing, and this is really important for all of you, don't empower people to do the risk scores that are not empowered to do the history and physical. The nurse in holding, preparing you for surgery, don't ask her to do the score. That's the wrong time. That nurse is trying to find out if you have the right if you have the right operation done on the right part of your body, if your lab is in order and so forth. She's not going to interrogate you with 40 questions. That's ridiculous. Also, when you come to see the doctor, when you sit down to see the doctor, and now you can't walk and you're going to have a major joint replacement. And what is on your mind with that doctor? How long am I going to be out? Am I really going to be able to walk normal? How much pain am I going to be in? Will you have a bad day? What are the complications? What can I expect? That's no time to do a 40-element litany of your history and physical, and if your aunt had a stroke. It's the wrong time. People doing those things at the wrong time will get the wrong answers. And what we have found is that as far as orthopedics goes, it's the same as everything else, but you have to determine the set point in your practice. So you have to take a look at 90-day results. You have to do live risk assessment, and that's why we want to empower the patient. And we're embarking on a program of voice recognition to make that easier, where you would get a phone call ahead of surgery and the computer would ask you all these questions and then put it into your record. I don't have time to go into it, but we also have data in fractures of the leg and casting. But there's just one other thing I want to say, and that is that we have a very good study coming out of Europe that patients who have a score of 11 or 12 and a hip fracture, up to a third of them have a preoperative clot. So a Caprini score of 12 in a hip fracture patient, beware. You better check that patient before you operate on them. Thank you very much for your question.
Thank you so much, Professor Corbetta. Now we fly all the way
Muchas gracias.
Thank you, Professor Corbetta. We fly all the way to Central America, and it will be the honor and pleasure of Professor Bottini to introduce the continental representative. Oscar?
Thank you, Sergio. Every time I have to introduce Dr. Luis Rodriguez from El Salvador, I cannot avoid mentioning his great wife, Wendy, who is permanently by his side, a brother to me and president of the Society of Phlebology and Nephrology of El Salvador. Luis, go ahead.
Thank you, Oscar, Sergio. Dr. Caprini, is an honor to be able to comment and ask about your presentation, especially in this time when the world is once again experiencing a significant increase in COVID-19 cases. Pre-inflammatory states, cancer, obesity, and metabolic syndrome, they have been recognized as factors to take into account to the complex pathophysiology in the thrombosis. Now, COVID-19 joined as a powerful stimulating factor of the thrombotic, immunologic, and inflammatory cascade with high morbidity and mortality if you not treat properly. My question, doctor. In countries where the tests for COVID-19 PCR are not universally available, and in the current community phase of the pandemic, the Caprini score could have the flexibility to start the score with a +2 in asymptomatic patient seeking care for chronic venous disease and his complications, with or without PCR test for COVID-19, and indicate prophylactic treatment, especially after a venous endovascular procedure. Thank you, doctor.
Thank you very much. It's an honor to have that question from you. And it's one of the things that's so exciting. And I pity people who haven't known people from around the world, is that the more countries you go to, the more people you see. We're all the same. The good people are all the same wherever they are. And they've all got the same questions, the same concerns. And your comments, in my opinion, are brilliant. And they're emblematic of what we need to be talking about. When you have a patient that that's fine to do the testing, but the testing isn't the answer. It's the clinical appearance of the patient, and it's an evaluation of the risk factors. And as you said, if patients have cancer, if they have a BMI that's excessive, if they have diabetes requiring insulin, if they have COPD, if they have a past history of inflammatory bowel disease, active inflammatory bowel disease, or one of those hidden obstetrical complications. That's baggage. And those patients needed to be treated more intensely than others. And the other thing is that depending on their level of baggage, I think that one has to consider doing increased prophylaxis. I'd like to point out something here very interesting. And that is that, and from my dear Professor Lobostov from Moscow, who's made a number of important contributions. He recently published an article that showed that Caprini scores are very high when they're 11 and above, that there was a lot of breakthrough thrombosis. So he did a trial, low molecular weight heparin alone, or low molecular weight heparin and pneumatic compression devices. And guess what? With patients with a score of over 11 who have low molecular weight heparin alone, there were 34 breakthroughs. There were 0 breakthroughs in the combined group with pneumatic compression. So he is defining for us when we should use compression. Now I noticed that Alan Davies is here, and we've talked about the GAPS trial and so forth. So applying this physical compression to everybody is a tremendous waste of money. We understand that now. But the thing is that there are specific groups that would benefit from this prophylaxis, and that's where we should use it. So again, in answer to your question, I think that patients should be scored. I like the Caprini score for this because we've also put the COVID elements into it. And by the way, Professor Lobostov has done this and has an additional 3 or 4 months of data. We're going to report back to us about how good this adding these additional factors for COVID was. But in the final analysis, the dose of anticoagulation can be increased. Yes, along with, as you alluded to, the use of appropriate antivirals, the use of anti-inflammatories such as steroids. But the caution here is, as I mentioned in my talk, we do have an incidence of pulmonary hemorrhage. Now, there is a low incidence, around 3%, in all the patients that have reported with bleeding. And the bleeding rate is highest when you're using ECMO, extracorporeal membrane oxygenation, or in patients that have kidney failure. So when you take those 2 groups out, the risk of bleeding is lower, but it's just something to keep in mind. Thank you very much for your question, and it's an honor to be with you and to have this back and forth discussion.
And thank you so much, Professor Rodriguez. Now we were supposed to fly to Czech Republic with the president of the Czech Society of Phlebology, but unfortunately he has been kidnapped in a parallel session that went way too long. But we have in this difficulty the opportunity of using our scientific director, that is indeed Professor Chi, who I'm sure has a question for Professor Caprini. Just a quick one.
Well, it's always nice to hear Dr. Caprini's passionate lecture on the thrombosis topic. My question was actually asked by Luis Rodriguez, but I'm going to rephrase the question, Joe. In your opinion, based on the Caprini score, and given what you have just said about the overall baggage that these patients carry, what would you say as being the cutoffs of Caprini score in terms of the different dosing of prophylactic? And I will use low molecular heparin as a guide. 5, a Caprini score 5. Would you do a basic prophylactic dosing? A Caprini score 11 that you will do the intermediate dose, or or a number greater than 15, then you would do a full dose anticoagulation. Just want to pick your brains on that particular detailed topic.
Thank you very much for your question. And again, I would just like to point out that the Chinese have done so much with this Caprini score in medical patients and surgical patients. They've contributed a tremendous amount to our understanding of this disease. And also one of the nice things that I think about the intensity of the Chinese is that they have pointed out deficiencies in the current score, which are very important going forward, and we have to adjust. So now on to your question. First of all, patients who have a score, in my opinion, all patients who are admitted need anticoagulation, and we would prefer low molecular weight heparin. If the score is over 8, then I would advocate doubling the dose of low molecular weight heparin. And in those with very high scores in the teens, especially if it's correlated with clinical symptomatology like respirators, decreased oxygen saturation and so forth, perhaps even selectively therapeutic anticoagulation. So I don't think you need necessarily to use the testing if it's not available in your country. But one thing you really have to do is to make sure that you analyze and strategize these results so that you have good risk assessment. You know who has what risk factors, what was given to them, and what were their 90-day outcomes. And as I'm sure that one of the weaknesses, and for all the time and energy over these it's almost 50 years that I've put into this risk assessment study, I'm kind of embarrassed a little bit because I can't present to you really good data on bleeding complications. I mean, a good bleeding score. We don't we have some various scores out there, but nothing really good with bleeding. So as I said in the beginning, anticoagulation isn't the total answer, but it certainly can be escalated to the point of being helpful as long as it doesn't increase the incidence of bleeding complications.
Thank you so much, and thank you so much, Willie, for the last-minute question. And now I have the honor of flying all the way to China, introducing Professor Jinsong Wang from Sun Yat-sen University, also deeply thanking Professor Wang and all the Chinese friends for the joint teamwork on the We Win China project.
Dear Professor Cabriner, it's very honored to discuss this COVID-19 and thrombosis with you, and appreciate your excellent talk on the new side of the thrombosis and COVID-19. I have a question about the anticoagulant choice. I mean, in the severe hospitalized patients, which coagulant is better to choose, the heparin or low molecular heparin? Does it related with the Caprini score, like a higher score use heparin to, to have a strong anticoagulant effect? Oh, and if we use the heparin, shall 83 level should be tested to avoid heparin resistant. Thank you.
Thank you very much. And it's a great honor to interact with you as well. And I again would like to commend all of the Chinese. I have dear friends in many Chinese cities who have done some great work in those huge hospitals in terms of prophylaxis. And your initiative in China over the past few years, where there's a great increase in the use of prophylaxis, the awareness of prophylaxis, is commendable. Now, on to a really, really interesting question. And this comes back to something that, this comes back to what I would call is, in my 43 years of practice, my secret weapon. Now, what is that? First of all, I believe that most patients who are admitted to the hospital and who have COVID-19, their low molecular weight heparin is the better choice. It's the better choice because it avoids a lot of IVs and interactions with other drugs. As far as unfractionated heparin goes, and remember, let's go back to history. We know that there's a 50% bioavailability of unfractionated heparin. And yes, it's great that unfractionated heparin has all these other properties, but only half of it goes to the clotting proteins. Whereas we know that low molecular weight heparin is 90% bioavailable, so that we get a much more consistent dose of anticoagulation. If there's anything we need in COVID, it's having consistency. So that's number one. Number two is that those all the patients who get a standard dose, and again, I've already talked about how to escalate the dose according to the score. But what in the world am I talking about with the secret weapon? Well, we know that many, many times and this happened in my surgical career, is patients would be at high risk of thrombosis and of bleeding. So what would I do? I would start a heparin drip and I would follow the patients. And at the slightest sign of increased bleeding, or if it's central nervous system, the slightest change in their neurologic parameters, boom, stop the drip. It has a 40-minute half-life and keep you safe. So that in COVID patients, where you'd like to use full dose anticoagulation, but you're worried about the pulmonary hemorrhages, you're worried about bleeding, that's when the heparin drip should be used. And then let's not forget that overall the incidence of heparin-induced thrombocytopenia with unfractionated heparin is at least 2 or 3% versus 0.2% or so with low molecular weight heparin. So that's another reason to use that. But now also don't forget about fondaparinux and argatroban. They're two very important, powerful anticoagulants that can be used in specific situations. And one of the things that our group prefers in patients who are on ECMO is to go ahead and use argatroban instead of the traditional low molecular weight heparin. As far as monitoring, we use the 10A is somewhat controversial, but the 10A can be used. The 10A may be better than the PTT, of course, in the COVID patients. So I hope that answers your question.
And we deeply thank Professor Wang and all the Continental expert representatives. We are 12 minutes in delay, and I was thinking that in Italy we have a tradition that is called the 15 minutes delay, that is the academic delay we have at the university before getting started. And since Professor Caprini is my true hero, and there is no chance that I'm stopping my hero because you are, of course, the hero of me and many others, and I don't want to take away to the others the possibility of enjoying the chance of making a question to you, we will have a 15 minutes delay. So we will welcome other 3 minutes from the audience. So Joe, just quick one, because I cannot stop you, but I will have to if you go too long. But please answer the question from the audience that is coming from Dmitry Kazian, who is asking, is there any data, Joe, that your score can also predict the risk of arterial thrombosis in COVID patients? Any data about predicting arterial thrombosis in COVID patients with the score?
The quick answer is we don't have data, but I would say that in patients at very high scores, they're more likely to develop arterial complications. The one thing that I would say is don't forget about paradoxical embolus. And that is with the patent foramen valley, 25% of the normal population have it. And if you have a clot and the clot travels and dilates that patent foramen in the right atrium, then that can lead to an arterial thrombosis, either a stroke, thrombosis of the arm, legs, or superior mesenteric artery.
Thank you so much, Joe, and thank you so much, Professor Kazian. Now we have the honor of having another giant with us today, another hero for many of us, Professor Davis. And of course, Will and I are just two little, let's say, minions who are in this moment trying to cover two delicate topics in this area. So the next topic is from me, and it is about the peri-procedural management in chronic venous disease. These are my conflicts of interest. And I was quoting Confucius over here, because you shouldn't do to the others what you wouldn't like the others to do to you, meaning that indeed this is a topic that is quite challenging. I started wondering if it is clear that we have an increased thrombotic risk in our varicose veins patient. And this is a good excuse, I say, to get started with the golden rule that our master, Professor Caprini, gave us. Always start, of course, with a proper risk assessment. And if we look at the Caprini score, indeed, we see that we have varicose veins as we have them in the NICE tool, even if in this case it is specified with phlebitis. This nice paper from JAMA is showing us that there is indeed an increased risk of DVT and PE for our phlebology patient. Then I wondered if the venous procedure per se has a clear risk in terms of thrombosis. And I have to say that I found it quite a big deal when I started looking at the literature, because you have papers like this one that are claiming no DVTs following many stripping procedure, even without low molecular weight prophylaxis. But in the same area, we see that we also have a word of caution showing that up to 16% of our patients could experience a thrombosis following an endovenous procedure. This is quite in line with an analysis that was done in 2013, showing to us that indeed we have around 1% of cases reported if we look by clinical diagnosis. But if we look better with the ultrasound, we can scale up to 10 times higher as a risk of having these DVTs. The paper by Barker in 2017 showed us no significant differences among the different procedures we are doing in the venous operating room or in our office. But I'd like to point your attention that there are no data in this analysis regarding the non-thermal, non-tumescent. It is interesting in this paper to notice that the first 30 days, foam was associated actually with less cases of DVTs following the procedure, not at 90 days and at 1 year though. If we go back to Panucci 2012, we see that the venous procedure per se can increase, of course, the risk for our patient. But I would say that we are in 2012 in this paper, which means another era comparing the one we are living now with so far more different techniques. So if we have to choose what to do in the peri-procedural phase, so starting from before getting inside the operating room, we could choose if putting or not compression stockings. And it is interesting to me to notice that if I'm in US, I have to do that for some weeks before getting a reimbursement for the procedure. While in UK, I have an indication of not using compression unless the procedure is unavoidable. And in Europe, in reality, we have an indication 1B of using compression for preventing swelling in chronic venous disease patients that indeed are the patients waiting for the procedure. But of course, these indications are not focusing on the thromboprophylaxis aspect. We could think, in case of patients at risk, to use pharmacologic prophylaxis. And in this sense, we have now two important reviews covering the effect of surodexide in terms of antithrombotic, anti-inflammatory, and endothelial protective agents that could have a role, but of course, further investigations are needed. Then we could choose, when we are in the operating room, if staging or not the procedure. And if we look at the guidelines, we know we have quite an heterogeneity, and we have also interesting new data coming out showing us that we could go concomitant to improve the quality of life, but again, no real insight in terms of the thromboprophylaxis. If we move forward, then we have to decide which drug we want to use. And it is interesting to notice how our Greek colleagues in 2012, in 58% of our colleagues were actually choosing to have always a thromboprophylaxis following the endovenous procedure, based on risk factors that were extremely variable and based on their different opinions. If we fly to Ireland, 2019, we see that 73.3% of our colleagues are always prescribing a thromboprophylaxis. And I'd like to point your attention that 71.4% of them are using one single dose. I think this will trigger some discussion, as it will trigger some discussion the fact that 46.7% of our colleagues are keeping the ongoing anticoagulation, just 46.7%. An interesting publication by Dattani showed us recently that in moderate risk patients, single dose of heparin is prescribed by 52% of our colleagues. 38% of our colleagues are prescribing 1 week of low molecular weight heparin in high-risk patients. Again, food for thoughts. Indeed, we have not so clear indications in the guidelines around the world, and more investigations are needed. In terms of which drug we want to use, of course, we can rely on the low molecular weight heparin, but we have also data showing that DOACs could have a role with no significant more bleeding compared to low molecular weight heparin. And we look forward for the results of the Step Ahead study, focusing on the use of surodexide rather than heparin, considering it is orally bioavailable, it has a longer half-life, and it has smaller effects on systemic clotting time and bleeding. I think it is clear that we need a proper risk stratification for our endovenous procedures and identification of proper prophylactic protocols. Let's say then we have done the procedure and we have to choose if we want to put compression or not. Well, in reality, also in this case, there is some controversy, because if we look at the guidelines in Europe, we have an indication 1B suggesting to use it to reduce the side effects, but not really specifying the thromboprophylactic aspect. If we look at the guidelines again in Europe, we have an indication 2B of using compression for improving the aesthetic results of a sclerotherapy treatment. And we could suppose this is associated with the microthrombi aspects of the pigmentation, but this is just, of course, a supposition. This could be in line with the results recently published by Ochoa, showing that sulodexide is improving the aesthetic results of sclerotherapy, reducing the hyperpigmentation. So once again, this could be maybe related to the clotting aspect. But more evidence is needed, and this is indeed in line with the consensus published by Professor Luri and many other colleagues from valuable societies, showing that we are based mainly on the best practice. Interesting paper by Tan is showing us recently that compression post-sclerotherapy could have indeed benefits in the short term, but evidence is lacking regarding many aspects. And I would add that if we really dive into the data to look for DVTs, we are not really finding solid data. We can see that there is a benefit in terms of thrombophlebitis eventually. Relying on the Cochrane 2018, we see that we have gaps to fill in the topic indeed of compression and hospital-acquired thrombosis. And these gaps have been indeed filled by the GAPS trial that is showing us that we were relying on a quite dated literature. So now we know that low molecular weight heparin could be used in these cases without compression. But we always have to be thinking physicians and also consider that the GAPS trial had just a very limited number of vascular procedures included in the analysis. And indeed, it has been published that we need more evidence on this topic to come to a real conclusion. It is important also to notice that the same NICE is pointing out the importance of sizing, because we could get the risk of comparing apples with oranges, if not, and also of having improper fitting, as reported in the literature in many of these investigations, something we reported also in this investigation of our group, showing that in reality, based on the lower limb shape, if there is no proper sizing, you get the risk of having even a progressive rather than graduated compression. As always, balance in the risk-benefit analysis that, considering the very low risk associated with compression, could allow us, of course, to experiment more with compression, but always being cautious of the socioeconomic aspect, because as recently published by Gerol, there is, of course, a huge expense behind this use. But this use could also lead to great benefits, like reported from this paper, that is showing us that proper compression immediately after a thrombosis could lead to a significant reduction in the venous obstruction. And indeed, a recent publication regarding the Caprini score is showing us that mechanical prophylaxis is still there. Going toward the conclusion, we could decide to use drugs after the procedure to reduce eventually the evolution of the disease. We know that the evolution and the recurrence starts very early, from the very beginning of the clinical stages. And we have data showing that MPFF indeed can have a protective role on the endothelium, as sulodexide does, particularly on the reconstruction of the glycocalyx. But of course, these are preliminary data that needs further clinical validation. In terms of clinical, I think it is interesting that the recently published consensus on the heat management is showing so many 2Cs. Even on the chemical and mechanical prophylaxis that should be tailored to the patients, 2C, even for this sentence. And it is interesting to notice that the Japanese showed us that indeed heat is extremely rare, and that ultrasound could be not so useful in the vast majority of cases. Yet, if we go back to the survey I was quoting before, the Greek colleagues are still doing that in 76% of cases in the survey of 2012. And in 2019, 23.1% of our colleagues in Ireland, which is leading again to the topic of costs, with $14,000 and more spent for detecting one single VT, that is not even leading to a lethal case, for which very probably the surveillance will have to change in the near future. In the near future, or actually present, I think we have new issues to take into consideration as well, because you see our Mickey Mouse over here that is a little bit sad, because now there is not just heat, there is also the EJIT related to the glue migration toward the junction, with a new published classification that is showing us that in 5.8% of cases it could happen. So further food for thoughts that I look forward for having with our honorary chair, Professor Davis. And with this, I will have the honor of 4 huge figures, and it is my deep pleasure to introduce Professor Orrego from Chile, who will make the question to me.
Hi, hello. Congratulations, Sergio, for your amazing talking. And well, I have a practice question for you, very practice question. What is your opinion about treating patients with chronic venous disease while they are taking oral anticoagulant drugs? Because well, I have a lot of patients in that condition, and I have an idea, but I want to know what is your opinion.
Well, I think it's a very interesting question. It is clearly reported, for example, also in the Korean guidelines that you can avoid to stop them. There are papers from JVS and anal vascular surgery also showing us that both in the great saphenous vein and the perforating veins, there was no significant differences in using of them. There are some paper, if I remember correctly, from Sufyan as well, showing that you could have a reduction in the occlusion rate, but in general, the indication is to keep the anticoagulation on, but at the same time, of course, you have always to consider case by case. In my practice, my only concern would be if I'm doing a revision of a saphenofemoral junction, so a recurrent case surgically, so with an heart or lip procedure. In that case, I would stop the anticoagulation. In all the other cases, I would keep it. I hope this answers the question. And now we move forward with Professor Bottini introducing our next key opinion leader.
Yes, we was together yesterday. Has always a real pleasure for me to introduce Dr. Rodrigo Rial one more time. He is head of the Spanish Society of Phlebology. Rodrigo, the floor is yours.
Hello, good morning, good evening, good night, good afternoon to everyone. Congratulations, Sergio, for your fantastic presentation. I agree with most of the topics and your opinion. And I would like to make a comment on the work that the interventional radiologist, Dr. Pilutua, and his colleagues, and it's disturbing for the high rate of 13% of endovenous glue-induced thrombosis. In my opinion, the key is the learning curve. In the work that you show it, in my opinion, this is an evident bias, not in their ability skills, I presume the authors have it, but in their experience in endovenous procedures. The papers published by them don't show experience in other endovenous procedures. I don't think that must exist a special gene for surgery, or for most phlebologists, surgeons, and vascular surgeons. We have a long previous experience with the endovenous thermal ablation. That is by far the most important factor trying to avoid this complication. Also, endothermal heat-induced thrombosis. And most interventional radiologists don't have this experience. What's your opinion about this, Sergio?
Thank you so much, Rodrigo, Professor Rial. I think the question should go to Oscar, because the real expert of education in these cases, Oscar, has been involved in many projects related to this topic. In my personal feeling, you're totally right. It's very important, independently also by the specialty, say, but to have a proper education once you approach phlebology, because it's not just a Saturday afternoon private practice activity, phlebology anymore. It's maybe a real specialty. And indeed, you see a migration of many surgeons who are very experienced in the arterial, needing more expertise in venous, and vice versa. In the literature, you take, for example, the example of Shiva, that from Spain, maybe you know extremely well. Milone showed us that it's extremely different, the results you're going to have based on the training. At the same time, in my personal opinion, if I think the first 2 lessons I was performing and the 2 lessons I'm doing now, and if I was doing a pain score evaluation at the beginning of my experience, it was totally different. So whenever we are looking at the pain scores in this procedure, I'm always wondering how experienced in the multi-center investigations they are. I think you made a wonderful call for teamwork all around the world. And since this session is dedicated to Professor Caprini, of course, to the Caprini score and the thrombotic risk assessment, but also to the peri-procedural venous expertise that all the colleagues should have all around the world. So it's really important, I think, we use this difficult time as an opportunity to gather together, at least online, and decide how to move forward our discipline. Thank you so much, Rodrigo. And then, Willie, it's your honor to fly all the way to Mexico and introduce the next speaker.
So next we have a very good friend to VWin, Dr. Javier Serrat, who's the head of the Mexican Academy of Phlebology and Lymphology, and certainly we look forward to attending their meeting or his meeting at the beginning of next year. Javier, please ask your question to Sergio.
Javier?
Open your mic. Open your mic, Javier.
And stop driving also.
Hello. Hello to everybody.
And pull over.
Thank you so much. Good morning from Mexico City. Congratulations, Sergio. Very interesting presentation. But according to the thromboprophylaxis after procedures, I want to know what kind of rate of compression do you prefer to use after endothermal procedures? Maybe grade 2 or grade 3, and why?
So first of all, I will go with millimeter mercury, not to confound all the colleagues around the world. And that's another thing we should work together, I think, not to express grades, because then we get confused in the literature. So we go 23, 32 millimeter of mercury based on the guidelines I was quoting before, combining also the aesthetic aspects. In reality, we could talk for hours about this, because as you know, compression has a hemodynamic effect based on the stiffness and also an edema control. So it's really depending what we are looking at. So in our practice, we go 3 weeks. We actually do 3 days and night, and then just days. But as I showed before, there is a huge variability in the guidelines around the world that is ranging in timing from 24 hours on the way to 3 weeks, and in terms of pressure from 16 on the way to 40 millimeter mercury. So again, I think it's a wonderful question, because it points out again the necessity of co-working internationally together to come to a more unified conclusion. Thank you so much, Javier, and we look forward for being virtually in Mexico in January, actually.
Thank you.
Now it's my pleasure to introduce Professor Sharipov from the Kazakhstan Venous Forum. Wonderful place and wonderful meeting as well. I have fond memories of that place. Ashkat?
Thank you for your kind introduction, Sergio. Thank you for opportunity to be in part of this brilliant webinar. And of course, congratulations, Sergio, for excellent comprehensive presentation. A HIT is a common thrombotic complication of endovenous thermal procedures. We see different rates of a HIT from study to study. And of course, need of find of predictions is beyond doubt. My question is, can ultrasound anatomical features of the saphenofemoral junction, in particular the diameter of the SFJ, be considered as a predictor of the HIT development?
Thank you so much, Ashkat. This is another very interesting question that is allowing us to quote and greet our friend Nuttaut from Bangkok, who did some interesting publications on this topic in phlebology in 2016 and also 2019, showing that the caliber could predict this risk. And also the fact that you are performing concomitant sclerotherapy eventually. Now, the interesting thing, I think, is what I showed as last slide, that the EGIT was correlated with the risk factor related to the caliber, but the smaller caliber, the higher risk. Again, I think HIT is important to be discussed, but at the same time, it is important to point out that we demonstrated that is extremely rare. There are many potential biases in the investigations related, I think, also to the risk factors based on how you are performing, for example, the same tumescence. So it's really important from a general standpoint to say that it is important to know about it, but I don't really feel that we should waste too much time on that, as demonstrated also from the Japanese studies I was putting before. So thank you so much, Ashkat. We look forward for seeing you in Almaty. And Willie, I don't want to choose my own question, so could you just pick up one for me and put me in trouble?
Yes, I will. So we have a question from the most likes. This comes from Dr. Hugo Navas. He says, excellent presentation, Dr. Giannassini. Question, are there any studies or data on the use of aspirin after thermal or chemical ablation as thromboprophylaxis?
Actually, up to my knowledge, in terms of aspirin, I'm not aware of the use of aspirin to prevent thrombosis in these patients. We are looking forward for the data of the step ahead that is indeed an anti-inflammatory drug that is acting as a dermatan and heparan sulfate, and that could be an alternative. But I might be wrong, and I invited the panel to answer the question if I'm forgetting some literature. So since we have the giant Joe, are you aware of any data regarding aspirin to prevent thrombosis after an endovenous procedure?
No, no, I'm not. And that's an excellent question. And I'm curious as to why we haven't seen that yet. But again, I'm looking forward to the trial, and I enjoyed your brilliant presentation.
So, Joe, let me for 1 second be in the bad cop and stop you, because I see in my screen, Jaroslav Strajček just was able to escape from the previous session. Jaroslav, you are with us, and you have the one chance of making a question to Professor Caprini. Would you like to make a brief comment since we are here with him? Unmute yourself.
Unmute myself.
Yes.
Do you hear me?
Go. Yes, you can make a brief question.
So I'm very happy to see personally, not personally, but virtually, Dr. Caprini, because in my clinic, we are using the modified Caprini score to evaluate the probably risk of deep vein thrombosis when we are performing the endovenous procedures. So I have to say, since the time we started with the score, we have a very low incidence of any complications. So we are very happy to have this score. We know that it's not the score which should be applied just only on the veins, because it's a score for everybody who has a risk before any kind of treatment. But we modified it. I have presented it several times. We have modified it to the veins risk, and we are very happy to have it. So I was very happy to see Dr. Caprini. I'm very sorry I couldn't hear that because there was a time collision. What I wanted, I don't have any questions. I just wanted to say what I found today. I have in my hands a paper which is called Antithrombotic Prophylaxis in Patients COVID-19. This is a material from Czech Society from Thrombosis and Hemostasis Guidelines, which I find is very important thing, because we know that the problems of deep vein thrombosis in people with COVID is very important to think. This paper has about 4 pages of direct say what to do. I cannot present the paper here completely, but there are some capitals, which is ultrasound screening of lower limbs and laboratory monitoring before, antithrombotic prophylaxis in patients hospitalized on standard beds, antithrombotic prophylaxis in hospitalized critically sick at ICU and CARIM departments, the length of antithrombotic prophylaxis. Then there is a scoring of the risk for the COVID patients, which has 7 questions: previous VTE, known thrombophilia, concurrent paresis or paralysis of lower limb, malignancy, stay in an intensive or cardiological unit care, complete immobilization more than 1 day, and age over 60. Each question has some number of points. You put them together, the same as in Caprini score. The 5th capital is antithrombotic prophylaxis in risk patients treated at home and limited mobility. And the 6th is the interruption of pharmacological prophylaxis when there are some hemorrhagic complication in the COVID patients. So this is what I wanted to say, that in Czech Republic, we also have the very good take care about the patients with COVID and thrombosis. So thank you for the possibility to speak.
Thank you so much, and thank you so much again, Professor Caprini. Now it's my huge honor to support one of our main golden rules in the Big Win. In life, it's not just where you go, but also who you are traveling with. So I could not be more honored and happy in introducing the one that I consider the brother I choose. And this is indeed Professor Chi from the University of California, Davis, who will be talking about monitoring thrombosis in chronic venous disease. And Oscar, don't be jealous, of course, you are a brother as well. But switch off your mic. Willie?
All right. Thank you, Sergio. Thank you, Oscar. I'll be go ahead and be short on my particular topic. Sergio asked me to give this timely topic on monitoring thrombosis in CVD or chronic venous disease. I do not have any disclosure related to this talk. Now, this is a study that was published about 12 years ago that may be familiar with many of us. This is the U.S. National Venous Screening Program that was actually organized by the American Venous Forum. And based on this study, what you could see is that the overall prevalence of I would say disease pattern using the C classification is mostly in the C1 and C2 category. But part of the screening program actually involved assessing thrombotic risk or VTE risk if the patient were placed in a high risk situation. Now, there are 17 questions, but question number 1 to question number 12 are general questions that everybody would answer to. Question number 13 to 15 are age-related questions. So you will get whichever point depends on the age group. And questions 16 to 17 are applicable to the female genders only. Now, the result of this venous screening program showed that about 40% of the participants were at low risk, but a good majority of the screening, I would say, participants were either at moderate risk, high risk, or very high risk. So this is actually something that we have to sort of recognize. Now, prior to the publication of the study, that a year prior, published in Journal of Vascular Surgery, that we already know that increased age and increased deep venous thrombosis risk correlated with increased C classification or clinical classification. Now, one of the studies that I want to point out, which is a study that Sergio already mentioned to at the beginning of his talk, has to do with this publication from JIMA. And it is actually a national registry from Taiwan that performed this massive study over 200,000 participants, because again, it's a national registry. Taiwan actually has a national health system, so it's able to organize all the data. Now, the assessment is actually varicose vein and its relation to risks of DVT, PE, and peripheral arterial disease. And based on that question, what we could see is that the hazard ratio is not small, it's anywhere from 7 to 8. And even adjusting for age, sex, and calendar year, you could see that result holds true. Now, this is a graph, again, Sergio has shown, but I want to tease out that you can see that the divergence of the graphs, even at the index or initiation of the registry at the very beginning enrollment on overall overlap for 14 years. And that is actually true for both DVT, PE, as well as PAD. Obviously, we're not talking about PAD, so that's why I'm only showing the 2 graphs. And you can see that that risk continue onwards in the upward trend. Now, despite of the fact that hopefully I have showed you that varicose vein or CVD itself is a risk factor for VTE, we also know that VTE predisposes to CVD. And looking at the study that was published 16 years ago in the Journal of Thrombosis and Hemostasis, you can see that in the C category of 5 to 6, there are certainly more patients with a history of VTE than not. Now, going back to the Achieve session last week with Professor Lurie, Professor Raffetto, and Professor Diaz, we know that CVD is becoming a recognized risk factor for VTE. Now, Joe, Dr. Caprini and Sergio gave a very good presentation about the different aspects of, again, COVID-related thrombosis and also per procedure prophylaxis. So I'm not going to dive too much in on the top 3 topics in terms of symptom history, D-dimer, and duplex or CT. PA, but going back to Dr. Caprini's emphasis on the importance of physical exam and history, and I concur with that fact. It is actually the most important element of our assessment tool is that history and physical. But I want to go ahead and focus the remainder of the time on the questionnaire that we currently have available related to the particular question on CVD. Now, improved VTE risk score is something that may be familiar with many of us. We could see that the VTE risk factors are quite known to all of us with, again, various scale up VTE risk score numbers. Now, the Badua score is another score that we're all familiar with, again, with different elements that we're all familiar with. But it's not until that we start to look at Geneva score that we actually start to see CVD or chronic venous insufficiency becoming an element or part of the element in the scoring system, although a very low number, meaning +1, but still a recognizable element. Now, that's obviously in comparison to all the major risk factors such as MI or cancer and so on and so forth. And again, from Dr. Caprini's score, we could see that visible varicose veins and swollen leg, which are not I would say, a definitive definition of CVD, but certainly part of that overall definition phenomenon, that we could see that the Caprini score also has some element of CVD in its system. Again, a very low score with +1. The Wells DVT score is not really a risk assessment, but rather more of a diagnosis or an assessment tool to help the doctor to diagnose the DVT. But we could see that there are certainly elements such as collateral and non-varicose superficial vein present, certainly be an element of the Wells DVT score. And last but not least, the Department of Health from the UK, we can see that varicose vein with phlebitis certainly is an element to that score. So I hope I have conveyed some simple messages to you all that CVD is becoming an established risk factor for DVT. And this is based on publication that we know of, and certainly based on the lectures from last week from Dr. Lurie, Dr. Alfredo, and Dr. Diaz. Clinical vigilance as well as history is still the most important factors in terms of our overall risk assessment. There are many national and international guidelines are becoming or encouraged the incorporation of these risk assessment tools into our daily practice in assessing patients' overall VTE risk. And again, the most important thing is to use it. Just like what Joe has said, it doesn't matter what you use, but you have to choose your scoring system and know when to apply it, because the risk assessment tool is actually a dynamic process, because any individual's clinical situation changes from time to time. And certainly, post procedure or post operation, these patients will remain at somewhat of a VTE risk. And with that, I will end. Thank you all.
And thank you so much, Willie, for being always so outstanding in your presentations. Now it's my pleasure to fly to Brazil, introducing our dear friend, Professor Carlos Carvalho, who is with us online. Carlos, can you unmute yourself and switch on the camera? If not, I have his question ready. So while we are waiting for Carlos, Oscar, would you be so nice to introduce from Egypt, our dear friend and key opinion leader? Oscar? Okay, since I'm left alone, at this point, I will make the question.
No, okay.
No, okay.
We have been working hard with a shipbuilding, a scientific and educational bridge between Latin America and Africa. And it is a pleasure for me to introduce someone who has also been developing many valuable online education initiatives. Dr. Fakri Ayman, whenever you are ready.
Thank you, Oscar. I'm ready. Thank you, Sergio. It was a very nice meeting. And I like the lecture very much, but I have a question for a particular case in COVID patients. May I ask you, what is the monitoring of the pregnant lady with COVID? What is the risk assessment in particular for this pregnant lady?
Okay, I'm going to try to answer your question, Dr. Fakri. Again, I'm sorry, I apologize, but my phone just rang and I thought it was the hospital. But I have your question typed to me that, are we talking about the original Caprini score?
No, the question is, does the idea of modifying the original score help to its amplification in certain situations like a pregnancy?
Yes.
Gotcha. Well, I mean, obviously, we have the master in front of us. You know, Dr. Caprini should probably be more appropriate answering those questions. But I think that overall, in terms of the risk assessment tools, pregnancy itself is a risk factor. I'm pretty sure that we all recognize that. But I don't think that we could take a particular event or particular patient situation and then not considering all the other risk factors. I think, you know, when we talk about risk factor, we're really talking about based on the patient's history and the overall phenomenon and overall risk. So a particular risk, yes, will certainly add to it. And that particular risk may be enough, may be high enough to pose enough baggage to the patient that, you know, some form of prophylaxis or whether it be, you know, whether it be low dose, intermediate dose, or high dose. But from that perspective, you know, I think that it's overall risk assessment. I don't know if Joe wants to chime in on that particular topic that Dr. Fakri just asked, since you're the expert.
Joe, would you like to have a brief comment?
Yes, first of all, a very, very nice lecture. And I appreciate all of your comments, and also from the Czech Republic. Many roads to Rome. And I think with these obstetrical patients, you treat them like any other patient you would do, with the addition of, if they're diagnosed with COVID, then that's where I would recommend using the modifications of the Caprini score. And of course, that has to be tested going forward. And that may be enough, as was just mentioned, to initiate thromboprophylaxis.
Joe, sorry to interrupt, but since we have also the honor of having Professor Davis with us, and I'm aware that NICE has a wonderful tool for OBGYN patients. Would you like the two of you to make a comment on these tools compared to the Caprini in this setting? Joe, what is your opinion, for example, in using Caprini rather than the tool?
So I think that both tools are very good. It depends on what you're used to. I have a great admiration for what the British people have done. And again, it's my illustration of there's many roads to Rome. So that the other thing is that as far as the overall tool, it's the only one now. We have some data, but it has really good data on preventing mortality when that tool is applied throughout the country. So I'm very impressed with that feature and the fact that they also talk about family history of thrombosis. Alan?
Dr. Davis, Alan, do you have a quick comment on this?
Yeah, well, I think Joe and I would completely agree. I think the key thing here is actually not to argue whose toy is the best, is actually to make sure that one of the toys is actually used by the clinician, and that actually if the clinician can't actually remember to use a tool, they use their clinical intuition and take a very detailed history. So I think Joe and I would completely agree. I think the key thing is that they get assessed, and yes, you have to assess their VTE risk versus their bleeding risk. But I think what's also important, just to mention, I apologize for going on, it's all very well to do the risk assessment, but if you don't then follow through with your risk assessment and then initiate an appropriate management plan, it is absolutely pointless.
Thank you so much. And indeed, we have the 15 minutes of academic delay, because when we are so high in academics, it's just a pleasure to be in delay. So we go back to Brazil now. I see that Professor Carvalho is with us. Carlos, can you unmute yourself? Unmute yourself. You're still mute. You have to unmute yourself. Okay, here you are.
Okay, hello.
Good, go.
Okay. Okay. Consider your large experience. What are opinion, Dr. Chip, about the recent publication of Medicine in 2019 showing the low sensitivity of ultrasound in thrombosis detection, showing about 50 false negative. Teniendo en cuenta, sí, creo que habla en Spanish.
Got it. He got it. Willie?
Teniendo, okay?
Yes.
Okay. Yeah. You want me to answer, right? Okay. Thank you. Thank you, Dr. Carvalho, for the question. I did go over that paper just a little bit, before you came on. So I think that the overall theme of this particular paper, which is a Chinese study, that from my standpoint, in digging into the details of that particular paper, I think that there's a lot of heterogeneity to the paper in terms of it's a meta-analysis. And so that's number one. And number two is that I'm not really sure how I would say applicable that particular paper is to our daily practice, simply because of the fact that most of the studies that the authors have quoted are in the 1990s. So which is what I consider as being a dinosaur age, because back, a decade old, in the 1990s, that the protocol for even DVT assessment not standardized. So I think that from that standpoint, there are a lot of questions as to the merit of that meta-analysis. And so that's how I would probably answer that. I certainly would not, believe, or actually not believe, but I would certainly question the result of that study being false or 50% false negative. So
thank you so
that
much.
was my answer to the question.
Carlos, Professor Carvalho, and now Willie, the mic is still with you to introduce our colleagues from China, key opinion leader from Fudan University.
Yeah, so next we have Dr. Shi Zhenyu from Fudan University, Zhongshan Hospital to ask me a question. Dr. Shi.
Professor Shi, you can unmute yourself. Okay.
Can you hear me?
Yes, we can hear you.
Yeah. Hello, everyone. It's my great pleasure to attend this webinar. And again, congratulations for Dr. Chi, your very impressive presentation. Actually, I have prepared the questions before via email, but actually from the previous talk and the discussion, my previous prepared question has been partially answered. So I want to change my question. So according to your presentation, CVD is a very evident risk factor for thrombosis. So besides for those hospitalized and the per-procedure CVD patients, do you think it is also necessary for us to monitor and evaluate those outpatients, but with very higher CEAP classification, I mean C4 and higher? Do you think it is also necessary?
That's a very good question, Dr. Shi. I think that, again, based on data that we already know of, patients are a higher seat category, like say, for example, C5 and C6, they're already at a high risk of VT risk to start with. But we also know that on the other hand, that when you have a DVT, those patients develop post-thrombotic syndrome, other manifestation of a post-thrombotic effect, and they will put patients or push patients to a higher seat category. So I think that from that standpoint, the answer is yes. But I think the overall theme is that I think that there are more and more modification of the current assessment tools that we have are going to have to incorporate CVD as a risk. I know that the Caprini score already did that, and I already showed you the Geneva score. And I think that there are more and more recognition of CVD as being a risk and be in addition to the modified risk assessment tools we currently have. But whichever number we decided to add it to, that's the question up to the individual assessment tools. Thank you for your question.
Thank you so much, Professor Shi. We fly now to Mexico, and it's my pleasure and honor to introduce Dr. Fernando Vega. Fernando, the mic is for you from the Society of Ramon Tournay.
Gracias. ¿Qué tal, amigos? Buenos días, doctor Chi. Excelente presentación. Gracias. Saludarlo. Pues mi pregunta es en el sentido que de la anterior. Usted ha puesto en relieve la importancia de la enfermedad venosa en estos scores de enfermedad trombótica, de trombosis profunda. Entonces, en tu experiencia, ¿qué porcentaje o qué cantidad de enfermos con varices o con insuficiencia venosa pueden producir trombosis, especialmente en tiempos de COVID?
Thank you, Fernando. It's good to see you online. I don't think that we have any data on a patient with varicose vein and COVID and DVT, because we know that COVID itself is a major VT risk factor. What Dr. Caprini has showed us, obviously based on the modified Caprini score with COVID patient, you have additional points added to it. Especially with those that have the dimer positive being COVID positive and have symptoms. I believe it was a +5 points. So, but from the standpoint of simply having CVD and developing DVT, I don't know if any of the major studies have actually put up an actual number. And the closest I could tell you is based on the Taiwanese study that was published in JAMA in 2018, that you could see that the hazard ratio, it's 7, anywhere from 7 to 8, depends on what you're looking at in terms of DVT or PE. So actually, it is not small. It is certainly a something that we as phlebologists, as vascular surgeons, have to appreciate, that CVD is becoming a more recognizable risk factor for patients to develop VT event.
Thank you so much, Professor Vega. And now, Willie, we open to the audience and we fly all the way to Professor Alberto Baquero. The question is in Spanish, so we try to translate it for you. It's prolonged prophylaxis with dogs in procedures at high risk with also comorbidities. What is your point of view in using it and your timing in using it?
Well, with DOAC is actually something that actually I have completely switched to. It's very rare do I ever use low molecular heparin or heparin nowadays, unless there's some issues with cost, with the patients. So am I getting the question correct about DOAC? Yes. In terms of procedure or just the DOAC itself?
The management with a DOAC in high-risk procedures.
Yeah. Actually, so with the procedures I do, I certainly, again, I also use Joe's Caprini score. That it depends on where the patient's risk, number falls into. Then I would certainly do the prophylaxis, and typically I use Xarelto at 10 milligram as the prophylactic dose I prefer to do.
Thank you so much, William. Thank you so much, Dr. Baquero. And now a special moment, because we have tried to engage the audience with a new initiative that is the best evidence-based comment from the audience. So previously, before we got started with the Achieve project, we sent out a call for 300 words of evidence-based comments on the topics of these webinars. And today, the selection was in favor of Professor Julia Anzovskaya from Pavlov Medical University with best evidence-based comment, again, in thromboprophylaxis in COVID time. So we will enjoy her contribution, achieving the stage, and then she will also achieve a special memory because the same Professor Caprini will make a question to her.
Good morning, good afternoon, good evening. Let me express my gratitude to the Professor Sergio Giannazzini, Professor Oscar Battini, and Professor Willie Chi for the high appreciation of my scientific commentary and the possibility to participate in such a brilliant project with the leading experts in the field of phlebology and lymphology. This is my affiliation. I am from St. Petersburg, Russia, St. Petersburg Medical University named after Pavlov. In the COVID pandemic time, poorly diagnosed thrombotic episodes occur in 2% of cases in clinical practice. Some patients have heparin resistance due to the antithrombin 3 deficiency. Cause of thrombotic events has not been studied in detail yet. There are no clear recommendations for the management of patients with thrombosis on COVID. Thrombosis cause may be due to the thrombocytopenia, and there is interesting meta-analysis, united 9 studies from different parts of the world about thrombocytopenia on patients with COVID. Thrombocytopenia occurs in patients due to the severe respiratory syndrome caused by viral infection and ventilation, which leads to endothelial damage, activation and aggregation of platelets with the formation of blood clot in lungs and concomitant consumption of platelets. Severe respiratory syndrome also entails milk-dick syndrome, which may also cause thrombocytopenia. There is another publication about abnormal coagulation on patients with COVID. Due to the fact that the lung tissue may be the site of platelet release and megakaryocytes, disturbance in capillary pulmonary blood flow may be associated with increased consumption and reduced platelet production. On the other hand, coronavirus can penetrate directly to the bone marrow and reduce hematopoiesis, and in addition to start an autoimmune reaction. Administration of fractional heparin in severe cases of COVID in the clinic has a positive effect due to its anti-inflammatory, anti-proliferative, hypolipidemic, anticoagulant, and gastrecogestial effect. Low molecular weight heparin are preferred due to the low risk of GIT. Due to the endothelial damage, seleudoxide can be effective. Due to immune origin of GIT, glucocorticosteroids and plasmapheresis can be effective, which should be verified by the results of randomized study, of course. Thank you for the attention.
And now a special moment in which Professor Caprini himself is making a question to Professor Giulia. Joe?
Thank you very much. It's a great honor to be asked to respond to this very nice presentation, and I applaud her for a great discussion and very stimulating thoughts. I really enjoyed the presentation, especially highlighting, which people forget about, the properties of heparin and low molecular weight heparin. Given solodexide's effect on inflammation, thrombosis, proteolysis, and protection and reconstruction of the endothelium, do you think we should be using it more in COVID-19, both for short and long-term prophylaxis in these patients? We know that COVID-19 attacks the endothelium with a spear-like injection into the endothelial cells. Thank you very much for your nice presentation.
Thank you so much, Joe, for the honor. Giulia?
It is a great honor to me to answer to your question, Professor Caprini. I think that it's very important to start the early prophylaxis and to reduce the endothelial damage. And solodexide has a proven effect of endothelium. So it seems to me that we need to start prophylaxis very early to reduce the severe complications. Thank you.
And thank you so much. And we invite all the audience for the future webinars to submit other comments so you can achieve the stage and enjoy questions from huge figures like Professor Caprini. So thanks again, Joe. And thanks again so much, Professor Davis, because with a huge figure like Professor Caprini, we definitely needed a huge wrapping up moment from a huge academic. So Professor Davis, the mic is for you if you want to share your screen. If not, we have your video ready. Perfect. We can see your slides. Go full mode.
Should just be getting there.
It's finding some traffic in the air. I see that, but it's not full mode.
It'll just take a second or two.
Okay. Is it a Brexit thing for which there is no connection with Europe, or?
Somebody's put the video on.
It is. Oh, really? Khaled,
Yeah.
are you overriding, or is this the?
Somebody's overridden it.
Khaled, is it you? Because it's surely not me. So I can see the slide in full mode now, Prof. So if you want to speak and maybe advance. We can see the slides, Prof. Can you hear us?
I can hear you. I think you've got my loaded talk. So is that all right?
Okay, so I can go with our loaded talk if you prefer, and then we'll get you live. But yeah. Okay, so let me just go with your video.
Right.
Ladies and gentlemen, it's been a great pleasure to listen to 3 fantastic talks from some of the most prestigious colleagues in the world. It's my great pleasure to talk about the talk given by.
Are there issues, Khaled? Can you hear? Please confirm.
Hello?
All is
Khaled?
good, Sergio. All is good, Sergio. Continue.
Okay, thank you.
Joe Caprini, as you will all know, he is undoubtedly regarded by many of us as the godfather of rats. And what do I mean by rats? Is risk assessment tools. He's very clearly illustrated to us that coronavirus patients are at a high incidence of VTE. But I would like to challenge his view in view of some of the latest data about the, and really to answer the question, are the majority of COVID patients post-discharge at greater risk of VTE than any acute medical patient? There's some very recent data that has been published in Blood that suggests that the rate of symptomatic post-discharge VTE following hospitalization is very low. And certainly, the NICE recommendations are very clear that with respect to discharge of patients with VTE in their emergency recommendations, it really follows the same guideline as for any acute medical patient. And basically, they highlight that it is research that is needed in this area to see if there is actually any benefit for the prolonged prophylaxis post-discharge. If we then go on to Willie Chee's talk, you heard very much about the screening program of the American Venous Forum. But I would like to ask and raise the question, is this really a cost-effective way of treating patients with venous disease? He's reinforced to us that their varicose veins are associated with VTE and PAD, and the converse relationship is also true. He also highlighted very nicely to us that in the majority of rats, there is often a reference to either varicose veins with phlebitis, or chronic venous insufficiency. If we then look at our leader who has organized this ACHIEVE program, he has talked very much about the assessment of VTE risk in varicose veins. And I think it is very important that the main key thing is that people should think about the VTE risk of their patients who are undergoing varicose vein procedures. Then there is the controversy about single dose prophylaxis. Now, I certainly know that there will be many of you who will say that there is no evidence for this. However, certainly in the UK and in Ireland, the majority of patients undergoing a varicose vein procedure will probably have a single dose of prophylaxis. And this is quite important because the NICE recommendations suggest that you should use a risk assessment tool and that you should use prophylaxis until the patient is fully mobile. And I think we would all agree that the majority of patients undergoing varicose vein interventions are fully mobile within 24 hours. So there is a controversy. I think it's also interesting to note that we had a little bit of a discussion about EHIT, but I would like to ask, please, could we have no further studies on EHIT because the investigation of it is really a waste of time. There was also some comment about vascular prophylaxis in vascular patients, but I would highlight that the reason that there probably is not a lot of evidence in vascular patients is because of the association with PAD and the non-use of stockings. But finally, I would like to suggest that the one thing that has not been discussed by any of our three speakers is the potential association of micro-VTE actually associated with the development of varicose veins. So, ladies and gentlemen, I would very much like to thank the authors and of the papers that have been presented. I would also like very much to thank the ACHIEVE program for honoring me with asking me to give a summation of the three talks. And I would like to congratulate Sergio on all his hard work. And I would also like to take this opportunity to offer you my heartfelt greetings for this Christmas period. I wish you all a very Merry Christmas.
Thank you so much, Prof. Prof, just one last final comment from you and Professor Caprini.
Yes, one of the great joys I've had over the years is all of the interactions I've had with Alan Davies. He has always been a very brilliant scientific investigator who asks piercing questions and forces you to go back and re-examine crucial details. He's done that again today, and I applaud him. We will continue to push forward together, Alan, and we will continue to explore these problems, and both of us will make our adjustments like we've done for years. And I think you are a great resource to this whole community about keeping us all on the straight and narrow path. Congratulations again.
Thank you so much, Joe. Alan?
Well, I will just say the converse. One of the best things of going to a meeting is to have a debate and discussion with Joe, and sometimes to deliberately take the opposite counter view to his, just to make the discussion more exciting. But I think we all agree with the issue about the COVID patients. What I wanted to highlight, and I would have said if I'd actually talked rather than the record, is that we've tried for ages to get a study up and running in the UK to look at the benefit of extended prophylaxis in the community, and we've hit against a brick wall, even with some of what we call the platform trials. But we're now getting a bit of leverage with this latest data, because we all made the assumption that we should give a blanket policy that all discharged patients ought to have at least 4 weeks of prophylaxis, and that's what we did. But now there's a big movement coming back, sort of suggesting that actually, rather than doing a benefit trial, as that's now the standard norm, whether we should be doing a safety trial. But I think it's something that we do need some more clear research on. And again, I'd very much like to commend you on bringing all of the community together to talk about these very important issues. Thank you very much.
And it's me deeply thanking all of you, and also asking for forgiveness if I took the 15 minutes extra of academic time. But with these academics, it was like going to a concert of the Beatles, standing on the shoulder of the giants, and you always remain in these concerts. So moving toward the end, we have, of course, the final greetings from Oscar and Willie. Oscar?
You nothing more to say. Just as we said yesterday, we do not get tired when we have to work in this education and scientific road, so being very close to the end of the year. Thank you all once again, and see you next Saturday.
Thank you so much, Willie, and thank you for being in such difficult day like today for you in the clinic, as you know.
Well, good morning, good afternoon, good evening. Thank you, everyone.
And indeed, thank you, everyone, the ones who have attended today's webinars. We look forward for welcoming the last step forward in the Achieve program next Saturday. We deeply thank once again Alpha Sigma as the main supporter through unbiased grants of this initiative, together with the media as a supporter. And I would say that we are a little bit less lonely in this walk toward this pandemic time and through this pandemic time. I take this chance to invite all of you to be part of the teamwork that is indeed going toward Dubai, based on the fact that we have around 40% of medical websites reporting fake news according to this publication, for which I invite all of you to report eventually encountered venous lymphatic fake news in this website. I deeply thank all the societies around the world already involved in this group effort that will finish with a Delphi consensus that we will be presented during the once-in-a-lifetime opportunity of connecting experts, informing patients like the one provided by the Universal Expo. And with this, I look forward for the first in-person chance to gather together again, and I deeply thank all of you for this online gathering. Ciao. Bye. And Thank you so much, Joe, for being so wonderful as always. Professor